The topic of lecture, Pharmacological Management of Pain and Anxiety in Children. World Health Organization defines pain as an unpleasant sensation that occurs due to the inevitable damage to the tissue. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. This definition emphasizes both the physical and emotional nature of pain. An additional note is consent to pain experienced by children. The inability to communicate verbally does not negate the possibility that an individual is experiencing pain and is in need of appropriate pain relieving treatment. Pain is always subjective. Children are anatomically and physiologically different from adults. Child perception of pain is subjective and varies widely, particularly with age. Such infants up to above 2 years of age are unable to distinguish between pressure and pain. After the 2 years, approximately, and up to the age of 10, children begin to distinguish it from pressure or heavy push. Children over the age of 10 are much more likely to be able to think abstractly and participate more actively in the decision to use local anesthesia, sedation, or general anesthesia. So children enter the teenager years, they are rapidly becoming more and more like adults. So, children's response to pain is influenced by age, family values, level of general anxiety, memory of previous negative dental experience, and coping ability. Method of pain control in children depend on anatomical and physiological features of tissue structure of maxillofacial area, planned dental treatment, child's age and his or her body weight, and psychological and emotional status. The different methods of pain control vary from simple behavior management to full intubational general anesthesia in a hospital. This graph shows the approximate frequency with which a particular pain control technique is used from local anesthesia through sedation until general anesthesia. There is a strong relationship between the perception of pain experienced and the degree of anxiety perceived by the patient. Painful procedures cause fear and anxiety. Fear and anxiety intensify pain. This cycle of cause and effect is central to the management of the whole patient. Good behavior management reduces anxiety, which in turn reduces the perceived intensity of the pain, which further reduces the experience of fear. Nowadays, we use the following methods of pain control in pediatric dentistry: local analgesia and anesthesia, general anesthesia, and combined method: local analgesia and sedation. The majority of dental procedures on children can be carried out using a combination of two techniques: behavior management and local anesthetic technique. Local anesthesia divided on non-injecting chemical and physical, injection, and needle-free. Physical non-injecting method include electroanalgesia, audio analgesia, cooling, and ultrasonic action. Electroanalgesia, or TENS, transcutaneous electrical nerve stimulation, has been shown to be very effective in providing anesthesia for restorative procedures in children aged 3-12 years. This technique also can be used to provide pain control during the extraction of primary teeth and as a deep topical agent to reduce the pain of local anesthetic injections. Mechanism of electroanalgesia. Large myelinate nerve fibers, such as those responding to touch, have a lower limit for electrical stimulation than smaller unmyelinated pain fibers. Stimulation of these fibers by the current from device for electroanalgesia closes so-called gate to central transmission of the signal from the pain fibers. In younger children, the level of stimulation is controlled by the operator. Children over 10 years can sufficiently understand the method to be able to control the level of stimulus themselves. If the patient operates the machine, the feeling of control can soften anxiety and aid in pain management. Next physical non-injection method, audio analgesia, also called sound anesthesia. This method is based on the establishment in the audio analyzer area in the cerebral cortex focus excitation, which causes diffuse inhibition in other departments of the brain. This is achieved by the impact on the auditory analyzer beat specific frequency band. Dental chairs equipped with headphones are available through which transfer calming music, white noise so-called. White noise is sound waves of different frequency and amplitude. It's, for example, like the noise of waterfall, sea, ocean, and so on. Cooling. This physical method in dentistry involves the using of acyl chloride. Acyl chloride, a volatile liquid, which during evaporation reduces the temperature of the surface tissue to produce anesthesia. This method is rarely used in children because it's difficult to direct the stream of liquid exactly without involving associated sensitive structures. In addition, the general anesthetic action of ethyl chloride should not be forgotten. So, non-pharmacological methods of pain control offer two advantages. First, systemic toxicity will not occur, and second, the soft tissue anesthesia resolves at the end of procedure. This reduces the chances of self-inflicted trauma. Surface anesthesia can be achieved by chemical non-injecting method. And now we are talking about surface or synonyms terminal, superficial or topical anesthesia. The success of topical anesthesia is technique dependent. Topical anesthetic agent will anesthetize at 2-3 millimeters depth of surface tissue when used properly. Rulers of intraoral topical anesthesia. The area of application should be dried. The anesthetic should be applied over a limited area, and anesthetic should be applied for sufficient time. When can we use topical anesthesia? Indication for surface or topical anesthesia in children. This is the main using of topical anesthetics is a pre-injection treatment. Also, it can be used for anesthesia of oral mucosa, for anesthesia for dental hard tissue, for anesthesia of the tooth pulp, and these agents have been used in children as the anesthesia for some intraoral procedures, including the extraction of primary teeth. You see on the slide that topical anesthetics are provided as a spray, solutions, creams, ointments, or even membranes. On the slide, you may see chemical agent used as anesthetics for topical anesthesia. Most common they are benzocaine, it can be as a spray, used as a spray, gel, liquid, 20%. Lidocaine is used in concentration 5 till 10% as an ointment, cream, or aerosol spray. And pyrimicaine as a solution and ointment. Spray, how to use it? Spray is the least convenient because it's very difficult to direct. Some sprays taste unpleasant and can lead to excess salivation if they reach the tongue. Additionally, the quantity of anesthetic used is poorly controlled. It is important to limit the amount of topical anesthetic used. The active agent is present in topical anesthetic in greater concentration compared with local anesthetic solution, and uptake from mucosa is rapid. Systemic uptake is even quicker in damaged tissue. Rules of the spray anesthetic using. You should ask the child to hold his or her breath from a short time to prevent contact anesthetic with the mucous membrane of respiratory tract. Spray is not recommended to use in children under 3 years old because you may provoke stenosis of respiratory tract. Contact 10% lidocaine spray with respiratory tract in children may lead to reflex respiratory arrest. As a result, stenosis of the breathways. Effective method of application of local anesthetic, topical anesthetic, is a spread cream on the end of cotton ball. Please remember that all the conventional intraoral topical anesthetic are equally effective when used on mucosa. The length of the time of administration is a key for success of topical anesthetics. Application of around 15 seconds or so are useless. Application time of around 3-5 minutes is recommended for topical anesthetic. It is important that topical anesthetics are given sufficient time to work because for many children, this will be their initial experience of intraoral pain control techniques. And if the first method unsuccessful, then confidence in the operator will not be established. Anesthesia of dental hard tissue used only in the treatment of caries in the cervical area, but please remember that it has a powerful psychological influence, psychological effect. And analgesia of the tooth pulp. For analgesia of the tooth pulp can be used application of liquid, gel or paste containing anesthetic agents. After that, you may continue treatment. Jet injectors. Jet injectors belong to a category somewhere between topical and local anesthesia. These devices allow anesthesia of the surface and to a depth of over 1 centimeters without the use of needle. They deliver a jet of solution through the tissue under the high pressure. The stream is delivered under the high pressure. Conventional local anesthetic solutions are used in specialized syringe and have been successful in children with, for example, bleeding of oral mucosa, where deep injection is contraindicated. Jet injection have been used both as the sole means of achieving local anesthesia and prior to conventional technique. This method of anesthesia also can be used alone or in combination with sedation to allow the pain-free extraction, for example, of primary teeth. Here you may see last generation of jet injector. The use of jet injection is not widespread for a number of reasons. Expensive equipment is required, like you see on the slide. Specialized syringe can be frightening to children both in appearance and in the sound produced during anesthetic delivery. In addition, the unpleasant taste of anesthetic solution, which can accompany the use of this technique, can be off-putting. Also, no needle is employed. The technique is not painless because used stream is delivered, solution is delivered with a big pressure. Nowadays, the use of topically active agent incorporated into materials that will adhere to mucosa and allow the slow release of the agent is a potential growth area in the field of local anesthetic delivery. Of course, such technique might prove to be of value in pediatric dentistry. But nowadays, it just in scientific investigation, you may see controlled release devices. Injection anesthesia. Injection anesthesia include infiltration anesthesia, is analgesia of peripheral nerve fibers and their ending, and regional block anesthesia. This is anesthesia of a nerve tongue. Rules of safe local injection anesthesia. Before you can do anything to a patient, even a simple examination, informed consent must be obtained. Of course, you should discuss the dental problem of the child with parents or caregiver and to approve the treatment plan. Medical history should be collected. All information must be registered in the dental medical card, and you need written or signed consent. If the plan of treatment changes, and along with it the frequency or nature of sedation, then it is necessary to obtain written consent for the change. The greater risk associated with general anesthesia requires specific written consent for each and every occasion that treatment is carried out under general anesthesia. After that, of course, your doctor should assess the patient's general condition to evaluate the nature, scope, and duration of dental treatment, to choose the type anesthesia, anesthetics, and the amount of anesthetic solution, to know the anatomical and topographic features of the area where anesthetic will be administered. Oral cavity before anesthesia is recommended to disinfect with an antiseptic. And please don't remember that you should assess the patient condition after anesthesia, local and general symptoms. Infiltration anesthesia. This type or anesthesia is the most often used in pediatric dentistry and works better because the alveolar bone surrounding the primary and erupting immature permanent teeth has a distinct but thin lamina dura. Alveolar bone has larger marrow spaces, greater vascularity, and fewer trabeculae than adult tissue. So, anesthetic is rapidly absorbed into the bloodstream and therefore quickly manifested as a pain reliever as well as toxic effect of the drug. Features of infiltration anesthesia technique in children. Before the anesthesia, please tell the child about upcoming feeling of pressure and little discomfort. Show the syringe in safe perspective. It's not necessary to show the needle. To convey the syringe out of sight of the child's eyes and maybe distract the child from a terrible object. For example, wear the glasses. For better adaptation of the child to the procedures of local anesthesia, treatments begins with the upper quadrant. This is the region that is the most easily anesthetized with the least discomfort. Needle should be sharp, short and narrow. Narrow needles are more likely to penetrate blood vessels than their wide examples. The choice of syringe used for conventional local anesthetic injection in children must allow aspiration both before and during injection. Anesthetic should not be cold. Cartridge storage in a refrigerator should be allowed to reach room temperature before use. And during injection of anesthetic, play should distract the patient. How to do it? For example, stretching the mucosa and gentle pressure on the lip between finger and thumb can help you achieve this. Or maybe use suction. On that slide, you may see method of distracting anesthesia with the use of cotton swab, for example. You must enter a small amount of anesthetic immediately after injection needle that will provide further manipulation painless because advancement of the needle and administering of the anesthetic into the dense tissue in children is painful. Direct deposition under periosteum can be painful, therefore the solution is delivered supraperiostally. One aspect of local anesthetic delivery that can contribute to discomfort is the speed of injection. Please remember that anesthetic should be administered slowly at a rate of not more than 1 milliliter every 15-20 seconds. So, you know that in cartridge usually it's present approximately 2 milliliters of anesthetic solution, and that cartridge should be administered for approximately 1 minute. New specialized devices for delivery of anesthetic solution can be used. On the slide, you may see computerized delivery systems, first and last generation of the devices. The use of computerized delivery system provide very slow delivery of solution. In the computer system, software is incorporated, allowing automatically perform aspiration test and monitor the progress of anesthetic in the soft tissue. So it can be very useful in pediatric dentistry. Regional block anesthesia. Example of regional block anesthesia, as you know, mandibular and maxillary block anesthesia, mental and incisive nerve block. Regional block anesthesia is recommended when infiltration anesthesia is not successful. For example, for posterior permanent dentition. In pediatric dentistry, mandibular regional block anesthesia is used most often. And I repeat, it can be used in children under 10 years old if other methods are not effective. In children, the mandibular foramen is low in relation to the occlusal plane. You may see on that slide. Thus, in children, it is easier to ensure that the solution is deposited around the nerve before it enters the mandibular canal. The height of insertion is about 5 millimeters above the mandibular occlusal plane, but in young people, young children, entry at the height of occlusal plane should also be successful. 0.4 in needle injection, approximately 5 millimeters above the occlusal plane or at the level of occlusal plane. The technique of administration is identical to that used in adults and is the best performed with the child mouth fully open. The direct approach is used, more recommended, direct approach when the needle is introduced from the primary molars of the opposite side. This method is a most common if you compare with indirect technique because as less needle movement is required after tissue penetration with this method if you compare with indirect technique. Next type of local anesthesia, intraligamentary anesthesia. This is a method of intraosseous injection with local anesthetic reaching the conscious space in the bone via the periodontal ligament. This method allows the use of small amount of local anesthetic solution. For example, the recommended dose per root is approximately 0.5 per 0.2 milliliters. The technique involves inserting you may see on the slide, inserting needle at the angle of approximately 30% to the long axis of the tooth into the gingival sulcus at the mesiobuccal aspect of each root and advancing the needle until firm resistance is met. The technique is equally effective with conventional dental syringes, but specialized dental syringe can be used for that technique. Pulpal anesthesia. Pulpal anesthesia action of anesthetic directly on the pulp reception. After pulp chamber partially open, you may insert the needle inside the pulp chamber and deliver the solution. Usually we use very small dosage. Intraseptal anesthesia. Intraseptal anesthesia, this is a local anesthesia when anesthetic is delivered via the buccal papilla, as you may see on that slide. Complications of local anesthesia. Complications of local anesthesia can be generalized and localized. Generalized complications include allergy, toxicity, and cardiovascular effect. Allergy. Allergy to local anesthetic is very rare, especially to the amide group, to which most of the commonly used dental local anesthetics nowadays. We mean lidocaine, prilocaine, mepivacaine, and articaine. Allergy to other component of local anesthetic cartridges may occur. For example, sulfites as a reducing agent which prevent oxidation of epinephrine. Allergy can manifest in variety of form, ranging from a minor localized reaction to the medical emergency of anaphylactic shock. If there is any suggestion that the child is allergic to a local anesthetic, they should be referred for allergy testing to the local dermatology or clinical pharmacology department. Such testing will confirm or refuse the diagnosis and, in addition, should determine which alternative local anesthetic can be safely used on the child. Toxicity. Toxicity, it means overdosage of local anesthetic. And overdosage leading to toxicity is rarely problem in adults, but can readily occur in children. Children over 6 months of age absorb local anesthetic more rapidly than adults. At the same time, this is balanced by the fact that children have a relatively large volume of distribution and elimination. It also rapid due to a relatively large liver. But please remember that doses which are well below toxic level in adults can produce problems in children. So, all drugs dosages should be related to the body weight. What is a treatment of toxicity? Of course, the best treatment of toxicity is prevention. So, prevention is aided by aspiration test, you remember, slow injection, you should remember about speed of administration of anesthetic, and dose limitation. We are talking a little bit later. When a toxic reaction occurs, the procedure is stop the dental treatment, provide basic life support, call for medical assistance, protect the patient from injury, and monitor vital signs. And one small complication of local anesthesia, cardiovascular effect. Cardiovascular effect caused by the injection of a dental local anesthetic solution will be due to combined action of an analgesic agent and the vasoconstrictor. Local anesthetic affect the cardiovascular system by their direct action on cardiac tissue and peripheral vascular. They also act indirectly via inhibition of the atomic nerves that regulate cardiac and peripheral vascular function. Localized complications of local anesthesia include pain, motor nerves paralysis, failure of local anesthesia, long-lasting anesthesia, and hematoma formation. Pain resulting from local anesthetic injection can occur at the time of injection due to the needle penetrating mucosa, too rapid injection, or injection into the inappropriate site. The site at which injection may be painful are intraepithelial, subperiosteal, into the nerve trunk, and intravascular. Paralysis. Paralysis of a facial nerve can occur due to malpositioning of the needle during injections, especially inferior alveolar nerve block. So just technique. Failure of local anesthesia. The inability to complete the prescribed treatment due to failure of local anesthesia can be due to a number of causes, including anatomy, pathology, and operator technique. I stop just on pathology. It's known that the presence of acute infection interferes with the action of local anesthetics. This is partially due to reduction in tissue pH, decreasing the number of unionized local anesthetic molecules. More importantly, nerve endings stimulated by the presence of acute infection are extra analgesic. You see, extra or hyper analgesia. The most common complication of local anesthesia in pediatric dentistry, self-inflicted trauma. The commonest site is the lower lip, but the tongue and upper lip can also be affected. This type of trauma can be prevented by adequate explanation to the patient and parents by the clinician. You should give recommendation to parents about the need to control the baby to prevent biting of the soft tissue, lips and cheeks after anesthesia. The choice of anesthetic for injection anesthesia. Nowadays, we use anesthetic with vasoconstrictor and epinephrine and without vasoconstrictor. Anesthetics with vasoconstrictor is not used in children younger than 5 years with diseases of cardiovascular system, endocrine disorders like diabetes mellitus and hyperfunction of thyroid gland, bronchial asthma, and severe somatic disease. After the age of 5, the anesthetic can be used with vasoconstrictor, epinephrine, but at low concentration, 1 to 200,000 or less. On the slide, you may see example of anesthetic for local anesthesia without vasoconstrictor, such as solution of mepivacaine. But please remember that mepivacaine has half-life. It's eliminated half-life elimination approximately 2 hours. Atticaine solution can be used without vasoconstrictor, but for that anesthetic, half-life elimination is approximately 20 minutes, less if you compare with mepivacaine. And with vasoconstrictor, most common, of course, atticaine solution. And as I told before, concentration of epinephrine 1 to 200,000. The next two slides demonstrate you the dosage of anesthetic according to the child age. It's better if you remember this dosage. For example, anesthetic without vasoconstrictor for children under 5 years and with vasoconstrictor for children over 5 years. But if you don't remember exact dosage, you may calculate dosage for child, use the formula from the slide. And we calculate, for calculation we need information about child age and child weight. So, as a result, we have percentage dose of anesthetic administered child from the adult dose. Of course, each child should be assessed on their merits and appropriate method of pain control used. And the vast majority of children are capable to satisfactory treatment using behavior management and local anesthesia alone. But in some clinical cases, child need combined analgesia. Combined analgesia, it means combination of sedation and local anesthesia. Sedation or conscious sedation is defined as technique in which the use of drugs produces a state depression of the central nervous system, enabling treatment to be carried out, but during which verbal contact with the patient is maintained throughout the period of sedation. Indications for sedation. We recommend to treat the patient under the conscious sedation if child ready to cooperate but with a high level of anxiety and lack effective coping strategies, and if treatment requires not more than 30 minutes. The aim of conscious sedation is to use a pharmacological agent to increase behavioral management, to decrease anxiety levels, and to calm and relax a patient prior to and during a dental appointment. The level of sedation must be such that the patient remains conscious, retains protective reflexes, and is able to understand and respond to verbal commands. Sedation by pharmacological methods may be obtained by two general routes. The enteral route involves absorption of medication across enteric membranes of alimentary canal. This route includes medication that are either swallowed, absorbed through the mucosa of the oral cavity, or inserted rectally. And you see, include oral, enteral, and transmucosal ways. And the parenteral route involves the administration of sedative drugs outside the alimentary canal. These methods include intravenous, inhalation, intramuscular, and submucosal administration, among others. Inhalation sedation. Inhalation sedation proposed to using of oxygen nitrous oxide gas mixture in relatively low concentration, usually 20–50% of nitrous oxide. And oral sedation, another very popular way for conscious sedation. Oral sedation, special pharmacological agents usually belong to a class of drugs called sedative, which exert their action by depressing the central nervous system used. You see examples on the slide of sedative drugs. Midazolam or dormicum, you may see the name, is more commonly used for pediatric dental sedation. It can be used in liquid. The liquid is bitter to taste, and some children may spit out the drug. To combat this, the drug is mixed with a fruit-flavored drink. The onset of the effect of oral sedatives is variable and largely depend on the individual's rate of absorption from the gastrointestinal tract, which can be affected by the rate of gastric clearance, amount of food in the stomach, and even the time of the day. In addition, the dosage is determined by the body weight, of course. Despite this, some children may spit out the drug, leaving the clinician uncertain about the exact dosage that was administered. For this reason, it is important not to let a child go to sleep in the dental chair while receiving treatment with sedation, as closed eyes may be a sign of sleep or with sedation, loss of consciousness, or cardiovascular collapse. Once the treatment is complete, allow the patient to recover in the quiet room until ready to return home. Criteria which are evidence of conscious sedation. You may see that patient eyes should be open. The patient is able to respond verbally to questions. The patient is able to independently maintain an open mouth. The patient is able to independently maintain an airway, breathing. Patient has ability, is able to swallow, and the child has a normal pink color. Sedation dentistry nowadays very popular because it offers several benefits for both the patient and the dentist. These benefits are patient relaxation, increased comfort, movements control, patient cooperation, control of gag reflex, reaction to painful stimuli is decreased really or absent, little or no memory of treatment, and time saving, fewer appointments needed. General anesthesia. The state of general anesthesia is defined as the absence of sensation artificially induced by the administration of gases or the injection of drug or combination of both. But if in case of general anesthesia, you need of specialist, such as anesthesiologist. General anesthesia can be performed as an inhalation anesthesia or intravenous anesthesia. For inhalation anesthesia, oxygen nitrous oxide mixture is used with a higher concentration with oxygen nitrous oxide, and at the same time, Torotan or Sevaran can be used. For intravenous anesthesia, thiopental natrium is used, sambrevin, ketamine, propofol, and another medications. The important feature of anesthesia, general anesthesia, is that the patient is completely without the ability to independently maintain physiological function, such as breathing and protective reflexes. If you compare, for example, with conscious sedation, you remember that in conscious sedation, patient independently maintain that physiological function. In general, no, that function cannot be maintained by the patient. There are different types of dental and general anesthesia, depend on the complexity and length of the time for the planned dental procedure. In dentistry, general anesthesia falls into the three main groups: outpatient, short case, dental chair anesthesia, traditionally with a nose mask; outpatient or so-called day stay intubation anesthesia can be performed in ambulance; and inpatient or hospital stay intubation anesthesia. Indications for the general anesthesia can be absolute and relative indication for the general anesthesia. The absolute indications for the general anesthesia, the allergy to the local anesthetic and uncontrolled fear. And the relative indications for general anesthesia. The presence of association malformation and diseases of a central nervous system, the presence of diseases of cardiovascular and respiratory system, for example, congenital and acquired heart diseases, asthma, and others; inflammatory process of the maxillofacial area like abscess, osteomyelitis. The child is pre-cooperative because too young to cope. Contraindications for the general anesthesia. As you see here, acute diseases of upper respiratory tract, because it's impossible to perform the intubation; diseases of the cardiovascular system in the stage of the decompensation; exacerbation of chronic somatic diseases; uncompensated diabetes mellitus; severe rickets, full stomach, and hyperthermia. And on the last slide, you may see the main differences between sedation and general anesthesia. And I want to repeat for you that for sedation, the patient has a consciousness; in general anesthesia, unconsciousness. All reflexes during the treatment in sedation saved, they are present and can be maintained by the patient independently, like breathing, swallowing, and they are not maintained in general anesthesia independently. Contact induced sedation is present and it's impossible in general anesthesia. For sedation, narcotic drugs are not used, but they can be used for general anesthesia. Of course, rehabilitation period for conscious sedation very short. It may take approximately 1 hour and more longer for general anesthesia. And now we finished our lecture and thank you for attention.